welcome again to another Expert Talk series. So glad that your extended family could come and join our family today. And I have just a little message for you that's extremely important. As you are aware, research on ALS is continuously progressing. At Everything ALS, we are dedicated to uncovering new discoveries, aiding in early detection, and working towards finding a cure for ALS. You can assist us by participating in our speech study. The purpose of the speech study is to enhance the diagnosis and prognosis of ALS. We are seeking participants to provide 5 recordings, each lasting 15 minutes, once a month, over 5 months. We welcome healthy participants as well as individuals diagnosed or probable with ALS to join us. To enroll, please visit everythingals.org/speech project and fill out our form. It means a lot to us, and it'll mean a lot to you because you'll feel like you're really helping everyone out who has ALS and the researchers. And you'll find that address in the chat. So thank you all for being with us tonight. And with that, I will turn it over to Christian Rubio. Christian, welcome.
Thank you so much, McFinn, and welcome everybody. I am really pleased to introduce tonight one of our a speaker who joins us from Neuvivo, one of the newest members of our industry consortium, which is an open innovation consortium dedicated to supporting the kind of research that you drive when you participate in these studies. And they've graciously offered up Dr. Matthew Davis this evening to talk with us. So it's my privilege to introduce Dr. Davis. So a little background on Dr. Davis is that Dr. Matthew Davis has over 25 years of extensive experience leading the development, approvals, and launches of small molecules, biologics, and therapeutic devices. He currently serves as the Chief Medical Officer for Neuvivo. Prior to his tenure at Neuvivo, he was the Chief Operating Officer and Chief Medical Officer at Tiziana Life Sciences, whose lead asset modulated the innate immune system, which will come up in tonight's presentation. Dr. Davis in his career has served as Chief Medical Officer of several multinational pharmaceutical companies, including Endo Pharmaceuticals and URL Pharma, where he spearheaded 3 NDA approvals and was actually the inventor on all 17 listed patents that contributed to Colchris, which is a treatment for different types of painful inflammatory arthritis. He was instrumental in the sale of URL Pharma to Takeda. And Dr. Davis's background is that he originally enrolled at the University of Pennsylvania as an undergraduate, and he received his pharmacy degree from Temple University, his medical degree from the Medical College of Pennsylvania. Dr. Davis undertook his surgical training at Brown University and his urology training at Washington Hospital Center. As a matter of housekeeping, of course, we will take Q&A from the audience at the end of the presentation, which Dr. Davis is going to present now. So Matthew, please, the floor is yours. Thanks for joining us.
Thank you very much. And I'm really excited to be invited here. And for the last 2 weeks, I've really been looking forward to this and tried to come up with a topic that I think would be very interesting. And McFinn said in the beginning that Everything ALS is dedicated for groundbreaking and new research. I wanted to put a little spin on this and talk a little bit about something old and how looking at something old, something that's fairly well established in the past, and looking at something in a new way, we can learn some new information. So making sure, hopefully my slides are visible.
Yes.
So firstly, it's very important housekeeping, and that is from conflicts of interest. I'm the Chief Medical Officer of a pharmaceutical company that's researching ALS. And whenever someone gives you a talk, it's always very important to know what their conflicts are so you can assess the information that they give you. So I'm not going to be talking about my company or the research that's going on in my company, but what I want to do is to talk to you about something different. So there's an expression in research: correlation does not imply causation. So Dutch researcher was taking a walk in the beautiful suburbs of Holland and looking at the beautiful, beautiful windmills. And the researcher noticed, wow, that one windmill, it's spinning very fast. And the wind is pretty brisk here. Continued their walk, and another windmill was spinning a little bit slower. And the wind wasn't that fast. And immediately came up with the hypothesis. Windmills control wind, and they cause wind speed. And this type of observation, it makes sense, everything, but we know that's not true. We know that's not true. Correlation does not always imply causation. So I'm going to be giving you some data. And just because I tell you that one thing occurs and another thing occurs, we always have to imply some skepticism and a filter. So I'm going to point some things out to you. And there's another important concept that I want to say. As scientists, we could predict large amounts of people, what happens to them. We're not very good at predicting what happens to an individual. And this is very, very important. You've heard all these news articles, don't do this, do that. As study shows, what's important about this is to understand that this data looks at a large amount of people, but it doesn't always tell you what happens to the individual. My grandmother was born in the late 1800s. She was diagnosed as a young girl of having rheumatic heart disease, rheumatic fever. And days before antibiotics, and her heart was damaged. And her parents were told she was never going to live to be 20. She drank 2 martinis a day. She smoked like a chimney. She was hit by a car. This is not apocryphal. She was hit by a car at 90. When she died at 97, she outlived 4 of her 5 cardiologists. So my conclusion could be that heart damage, smoking, and drinking prolong life. What I'm trying to say is, as I go on to this data, I can predict the large amount of people, what happens as a group, but not the individual. So let's talk about ALS now. What do we know? And just talking about in general, nerves in the brain and the spinal cord are affected. There's a similar pattern of damage that's seen in the spinal cords. Muscle weakness and muscle wasting occurs in ALS, and eventually the nerve that goes to the lungs are affected. And our ability to breathe, to exhale, that's called vital capacity, is eventually affected due to this weakness. And at the end of the day, damages to the nerves and the junctions where the nerves and the muscles meet appears to be caused by the body's immune system. What do we not know? Why do people's progression vary? They vary, but why? People's symptoms vary, but why? There are groups of people that are more prone to get ALS, but why? Why are younger men more prone to get ALS than younger women? Why? And this is a bit controversial, but why is the rate of married couples that both have ALS higher than you would ever predict? So let's talk a little bit about a little medical background that helps with this story. So I'm going to set the stage for some of this data. So there's something called C-reactive protein. And one of the ways your body deals with inflammation, with dealing with something that's wrong with your body, is to release C-reactive protein. And this protein activates part of your immune system, your ancient immune system called the innate immune system, and very specifically certain cells. And this part of your immune system called the innate immune system, it turns on immediately, very, very quickly. And it's there to prevent the spread and movement of foreign pathogens throughout the body. So it goes on very quickly. Your body reacts quickly. So that's one bit of data is C-reactive protein That's how we are going to react to something that the body has recognized as not right, foreign, dangerous. What's creatinine? Creatinine is a substance that occurs when your muscles break down. Now, all of our muscles are constantly breaking down, being built, breaking down. So we always have creatinine. So it is passed through your body through your urine. So generally, we use this in general in medicine to test your kidney function. If your kidneys are not working as well, and you're not urinating out creatinine, it goes up, and it's a measure of kidney function. But what is it basically? It's that breakdown product of muscle that's in your blood. So I just want to start out with a couple of scientific facts. Now let's talk about the SCREAM study, and that is the Stockholm Creatinine Measurement Project. So there's a little bit of background. So in Stockholm, there's only one healthcare system. There's only one provider in all of Stockholm. So it's very easy for them to collect data. So 2/3 of all of Stockholm received at least one serum creatinine assay in 2006 to 2011. So when they looked at all this data, they found out in the city of Stockholm, there were 575 patients that had ALS. So they wanted to do a study. So they matched these 575 patients to roughly 4 times that amount, 2,625 people who do not have ALS, but they were the same sex, the same weight, roughly the same background, similar labs. So they match them up as controls. So I want to set the stage. So now you have a large amount of data of patients with ALS and patients that don't, that are similar to those patients in all regards. And they looked at some data. So how'd they do, at least in matching these control patients? The controls are the ones that don't have ALS. And you look at the ages are pretty darn close, 65 versus 65. The percent male is identical. These are very, very closely matched. And there are other outcome measures that they match very closely. So as a scientist, you say, okay, this looks good. I'm comparing apples to apples. So what do they find out? So to orient you to this graph, you have at the 0 line going straight up and down, this is when a patient was diagnosed with ALS for the first time. And this line is looking at C-reactive protein. And your x-axis is months before or months after they found out that they had ALS. So the pink line are patients with ALS, and the blue line are patients that were matched to them. They don't have ALS. And you look at this and you say, wow, this is very interesting. And roughly about 1 year, 12 months after someone was diagnosed with ALS, the group of ALS C-reactive protein, remember, that's the protein that goes up when you have inflammation, starts going up. Kind of starts going down, though it's interesting, towards the tail end of the study. And what I've done to sort of guide you in this talk is every time there's a windmill, and remember, we talked about the windmill. Windmill's not making the wind, but I can incorrectly make a conclusion. Pointing out here, what's happening? Why all of a sudden, sort of towards the end, it looks like the C-reactive protein is going down? The problem with getting older is things happen to us. And as we get older, we wind up getting certain diseases that also cause inflammation. And what you can see is when they broke this down into 2 groups, those that are less than 67, those that are greater than 67, you look at the blue line. The blue line are the people that don't have ALS. And you start looking at the blue line over here, the people over 67, those that don't have ALS, the blue line is going up, up, up in those that are 67 or older. Why? as we got older, we wound up getting illnesses, and we wound up getting illnesses that cause inflammation. So our first sort of interesting windmill is we find out that it's really tough to distinguish once you're past 65, 67, an inflammatory disease, because you wind up getting something. So it looks like, well, I guess below the age of 67, there's a fairly nice difference. And we don't know why. Remember, we talked about the windmill. We see this, that there's a big difference. Now, the study is called SCREAM, and SCREAM stood for creatinine. Why creatinine? We looked at the same patient population. We looked at their serum creatinine. And remember, that's your muscle breakdown. And that's the measurement of what your muscle breakdown is in your blood. And 1 year before being diagnosed with ALS, the ALS patient's serum creatinine starts dropping. Starts dropping 1 year. So is it prognostic? As a researcher, do I say, wow, a drop of serum creatinine can predict ALS? That's one way of interpreting it, but that's a windmill. So it doesn't mean that patients with ALS have kidney damage. That's not where we're measuring it. What happens is, I'm going to go back. ALS is not damaged. Diagnosed quickly. All of you that are on this call were not instantaneously diagnosed with ALS. You had symptoms, you got it. Immediately you got the diagnosis. A lot of you had a long journey along the way before you were diagnosed with ALS. And what this data is showing us is two things. One, before people were diagnosed 1 year, they could measure a difference between groups that had ALS and don't have ALS, and they can measure a drop of muscle. Wasn't their kidneys that were damaged. It was the amount of muscle that patients had start to go down. So it's a very interesting correlation. Why would muscle go down? And this is the first thing I wanted to talk to you about that might be new to you. And there's many, many reasons that you would think that muscle mass starts going down with ALS. Could it be activity? Could it be muscle wasting because of nerve damage? There's another way of thinking about this. We talked that C-reactive protein is what our body does when you have inflammation. But how do you make C-reactive protein? You need 3 amino acids, 3 building blocks in your body to make C-reactive protein. And there's not a lot of sources in your body to make it. And the biggest source by far is your muscle. The more inflammation you have, and the more that your body is not able to turn off this inflammatory cycle, the more your muscle is broken down by your body to make C-reactive protein, which is your body's attempt of trying to deal with an inflammatory process. So the innate immune system is involved. You're part of your body that wants to repair the damage of, in a case of ALS, a misfolded protein, whether or not that's SOD1 or another misfolded protein. Your body detects that and says, this shouldn't be here. And I'm going to eat that. I'm going to attack that. I'm going to fix that. And that's inflammation. And your immunity gets revved up. Your body starts making C-reactive protein. It has to make it somehow. It starts eating and chewing up muscle to create the C-reactive protein. So I'm going to start off with a new hypothesis, new way of looking at this. There's an imbalance in your innate immune system. And what happens in patients with ALS is you have protein that your body is recognizing as not normal. your body has an attempt to deal with that. And basically, it will send out cells, the macrophages, which is part of your innate immune system, to destroy that protein right where your nerves and the muscles hit. The body will start making C-reactive protein, a very normal response. And the C-reactive protein, this circle, doesn't stop, and you keep on having more inflammation. Your body makes more C-reactive protein and starts eating up the muscles. So the hypothesis is maybe C-reactive protein is a biomarker for ALS inflammation, and maybe serum creatinine, although it's a measure of muscle, is a biomarker for ALS inflammation. So let's test some of this. Same data. So this is still the Stockholm patients. And someone asked the question, okay, I'm going to look at everyone in this database. And I am going to say, well, I'm going to look at half the group with ALS that had high C-reactive protein and the other half that had low. And they just sat and picked the top 50% and the bottom 50%. And they followed them, and what they looked at is their probability of surviving 2 years, 4 years, and 6 years. And again, remember, when I show these curves, people misinterpret it. And people misinterpret, and they go, wait a second, I have this % chance of living this year. That's not what these curves say. And again, this is for large amounts of people, not individuals. When you look at this curve, you see that patients with high C-reactive protein, remember that's a high amount of inflammation, have a shorter life expectancy. So it could be a predictor for large amounts of patients on how the ALS is progressing, a biomarker of ALS. And when they looked at serum creatinine, the difference was even greater. So patients with lower serum creatinine, those that had less muscle, had a higher chance of mortality than those with a more large amount of muscle mass. So there is not a take-home message that you can immediately go to your doctor and take a look at this lab and then predict yourself. That's not what I'm saying. What I'm saying is when you look at a large amount of people, these two markers of inflammation, C-reactive protein and serum creatinine, they seem to now be related to each other. Your C-reactive protein goes up, you chew up your own muscle, your muscle mass goes down, and it looks like the people that have this type of an inflammatory action with ALS, it looks like there is a change in mortality, your life expectancy. And this helps guide us to look for treatments for ALS. So my final thoughts is we have a new hypothesis, and serum creatinine could be a biomarker of ALS. Now, is this another windmill? Further questions have to be answered. So to see if there's a link, there's logical ways of following this. Is lower C-reactive, lower serum creatinine linked to vital capacity? Remember, we talked a little bit about vital capacity. Vital capacity is your ability to basically breathe, to be able to have a lung full of air and to move that lung full of air in and out. And your diaphragm, the muscle that controls breathing, is directly affected. Your phrenic nerve, the nerve that goes to your diaphragm, can be affected. So if there's a correlation, you would assume that serum creatinine might be linked to vital capacity. Does ALS treatment increase serum creatinine? Does it improve it? And it's something to be tested. Does ALS treatment affect vital capacity? Every year, ALS patients, as people progress, lose vital capacity. Can we change that loss of vital capacity? And I think that some of this research that I presented to you today out of that Stockholm group raises a lot of very interesting questions that need to be answered. So I want to thank you, first of all, in advance for listening to this. And I hope that this gives you some new information to think about with ALS. And I'm going to stop now and take any questions that people have. And I look forward to hearing from you.
Thanks, Matthew. And we do have a question from the audience right out of the gate. And the question is, why does ALS science refuse to try or seemingly refuse to try multiple compounds? For instance, immune system action and TDP-43, some gene or mitochondria, et cetera. In oncology, multiple compounds have been successfully used for decades.
So I can't speak to other people. I can sort of go into sort of a general way of looking at it. And that is, science is an evolution, is a slow evolutionary process. And as we learn more information about disease states, one observation can change the way we look at things. So this data existed and was published 5 years ago. But in the last 5 years, there has been an explosion of new data that is starting to implicate ALS as an autoimmune disease, or a disease of the innate immunity, more specifically. So I think in one regard, we go where we think the science is. To give you an example, about 2 months ago, when I first met McFinn and everyone at these conferences, I gave the story in medical school. I learned my first year that I cure all ulcers by cutting them out. By the third year of medical school, I learned that I give people antibiotics. And it wasn't that ulcers changed. It was one person, and it was one person who came up with this observation, who changed the way the entire science in the field was looked at. So more research is better, more diametrically opposed viewpoints, and talking about it in front of people. And please remember, all of you are subject matter experts also. All of you are on your own quest, and you are learning things from different areas. I don't know the single source of truth. Do I know if homeopathic, naturopathic? Do I know if Eastern? Do I know if Western? Do I know if biologic? Do I know if small molecule is the answer? I don't. I do know that the information I shared is very interesting observational data that we need to research. And I think there's many good ways of trying to answer the questions.
Thank you, Dr. Davis. And really, it's a pleasure to have you here. And the next question was, the CRP is a non-CNS petraxin. What is the data on the petraxins made in the CNS and non-CNS tissue?
I don't have that information. And the data that I was able to present to you, the reason why we have this is because serum creatinine is such a normal thing to test. So whenever you have a metabolic profile, when you go to your doctor, so part of your physical, they give you something called a Chem7, a metabolic profile. And because kidney issues are so common, we always check for serum creatinine. And that happened to be the reason why the serum creatinine was checked in this study. And then when patients were diagnosed with ALS, or they had other conditions that were inflammatory, that they happened to get C-reactive protein, that happened to be checked. And also remember that data was back in 2010. So that data doesn't have all of the newer tests. So I don't, it's a great question, and I don't have that data.
Thank you. Thanks, Doctor. And so the next question is there a role for antibiotics controlling, sorry, I just lost it again. Is there a role for antibiotics controlling this inflammatory response?
It's a really broad-based, interesting question. I'll always start off with the correct answer, and that is, I don't know. But let me go into the question and possibilities. So when people talk about antibiotics, it's a lot more complicated. So if you look at something like doxycycline, which also has a direct reaction on MMPs, it's an interesting question because MMPs are implicated in inflammation. For a while, they were looking at heart disease, doxycycline and MMPs. So it's one interesting way of looking at inflammation. And there are other reasons that the question is really intriguing because the antibiotics have been implicated. What would antibiotics do to your microbiome, which would probably have some effect on some of the systemic inflammatory effects that you see? I don't know. I think it's an intriguing question, I guess, both on both of those points between MMPs and other areas. But I don't have that data, but it's very intriguing.
Thank you. The next question is, about how we actually measure the clinical trials. There is, even though there's a large variability, a lot of the literature, and also in clinical trials, we say average decline in taking ALS-FRS as, a measurement. Average is 1 point per month in at least the first 4 years since diagnosis. Do you find that research as average is still true, or is it variable in your research?
I'm going to go one level above that, and say, I think it was 2019, the FDA came out with a really important guidance, and they acknowledged that ALS, one size doesn't fit all, that it's heterogeneous. In English, it's variable, and there could be various causes. People progress differently. People have different symptomatology, and it's very difficult to research in a couple of regards. One, the fact that the presentations and the progression is so variable that you're not having the exact same patient population. The ALS FR score is it's a good measurement, and the question would be on this heterogeneous population, is it consistent? And it's something that's not answered, and it's another reason why I believe the FDA wanted us to look at such a various amount of information when we were researching ALS, to try to come up with what's going to be important to patients and what in our research is going to be affected with treatments versus placebo. So I think it's the population you look at. It happens to be also, I'm going to be careful when I say the luck of the draw, but if you wind up having people with familial, you have people with non-familial, you have an imbalance in your population, I think you might get some difference in results also. So I don't have a pat answer if what we're seeing is changing in clinical research, but because of the varied nature in ALS, I see how different studies can give you different results.
Thank you.
We just had an additional comment that before antibiotics, CRP was a biomarker for pneumonia prognosis. If someone had pneumonia, CRP would rise and then would come down just before the crisis in pneumonia when one would begin recovery. CRP now rises when ALS patients need non-invasive ventilation, and research is ongoing with respect to whether CRP monitoring helps improve NIV treatment. Any additional thoughts on comments on that and how cross-applicable that is to further understanding?
I think that CRP really appears to be a great biomarker when you look at that larger study on inflammation. And then, since there's such a beautiful correlation also with the drop of muscle mass showing the drop of serum creatinine, it could be a surrogate, and I use that word very carefully. It could be a predictor, maybe, of then your ability to breathe, your vital capacity. So I think that research is needed to look at the correlation. If I treat someone with, however you want to treat them, if I treat them with a pharmaceutical agent, or I treat them with some proactive measure, am I going to be able to change the requirement for ventilation, or more importantly, prevent? Could I change the decline of vital capacity? which could be predictive of life, morbidity, mortality, of long-term survival. So I think that that research needs to be done. I think that research needs to be published. There's one caveat, and that is if you don't fix the root cause of ALS, this is very, very important, you're always going to have misfolded proteins, if that's what you believe one of the pathogenesis of the causes of ALS. So you're always going to have your innate immunity starting again and attacking. So the chances of your CRP just dropping and staying down is going to be different than a pneumonia. And pneumonia is a binary event. You have it or you don't. And if you're cured of pneumonia, you're cured of pneumonia. For ALS, unless a root cause cure is done, and I can give you gene therapy or something that we don't have now, and you no longer create this protein that your body is attacking, your CRP is always going to stay higher. You can fiddle with the immune system and bring things down, but eventually it's going to go back up again. And I think that sort of way of rebalancing the immune system is one of many promising ways of researching ALS.
So another question is that, are there any studies that isolate amino acids that ALS patients lack, and can we replenish them to reduce CRP?
That is a really intriguing question. So I believe that in the early 2000s, Merritt actually did a study, if I remember correctly, that she gave creatine. And the thought process was to try to bring up serum creatinine. And I think that that approach, although it didn't work then, I think it was sort of visionary of this later research, which I just pointed out. And that was the fact that, shucks, there are 3 amino acids that are constantly being chewed up. So the question is, well, instead of it eating my muscle, can I be taking the supplements? And I don't know the answer to that. The ultimate would be to stop the immune system from continuously trying to make large amounts of C-reactive protein. And if we can get the immune system to sort of stop that signaling, that would be a way of preserving those 3 essential amino acids, which the body is using. So long story short, I'm not aware that amino acid supplements, I'm not aware that it won't help. I'm not aware that it will help. I'm not aware of research on either way. And I think the ultimate goal would be to sort of rebalance the immune system to prevent that cycle.
Thank you.
Thank you. And so the next question has a little bit of background to it. Essentially, a person who's had a great PCP for 10 years in November 2019 found in annual lab work that the person suddenly had non-alcoholic fatty liver. Would that account for increase in creatinine and CRP numbers? Subsequently, the person was diagnosed with ALS in May 2021. Could there be any potential correlation?
I don't know. Not knowing the patient, not knowing the entire history, I'm always safest to say that I don't know. I will say a couple of general caveats. And your inflammatory state could be caused by a lot of different things, whether or not you are talking about fatty liver, whether or not you're talking about any process in the body that could increase CRP. The body is very non-specific. It has a couple of tricks, and whatever activated your innate immune system, eventually, when you create your CRP, if that CRP doesn't start going down, eventually you're going to have to continuously replenish the CRP. And eventually, those 3 amino acids are going to have to be supplied somewhere. And remember, there's a generalization. This is looking at data at 575 patients with ALS and their case control. No, I don't know the correlation there. It's certainly possible, but I would need to know more information.
Thank you. And talking about, causation and correlation, the next question is, do you believe that CRP production could be the cause of muscle mass? And also, do you know any study of CRP that has been correlated to neurofilament light changes?
Okay, that's a very interesting question, and the problem is time. So what I mean by time is the study that I told you about occurred before NFL, and occurred before that was such an important and hot topic. So the correlation, I don't have it. I'm not aware of if any of the physicians or any of the other people here are have that. I don't, because the SCREAM data was done in 2010-ish on, and that information was not captured. And then I think, what was the first part of the question? I apologize.
Is muscle loss, causation? Do you believe that CRP production and muscle loss is correlated or caused?
So, the slides that I showed were very interesting, and it's not direct. So what I'm going to do, and I apologize, but I'm going to quickly put on a slide in one specific slide that I had up. So again, I apologize for everyone that I'm going to go very quickly. Okay, this is what I wanted to show everyone. If you notice that we're looking right now at C-reactive protein, it starts going up roughly 1 year after diagnosis. If you look at serum creatinine, you notice it's going down 1 year before diagnosis. So it's not a one, this data does not make you think there's a one-to-one comparison. Your C-reactive protein goes up, your serum creatinine goes down. It's not mapping out to that. It looks like there's an increase in C-reactive protein, but the correlation of a one-to-one relationship, it's not temporally there. There's a little time frame difference between that. So hopefully that can answer a little bit of the question. More research would need to be done.
Thank you. And do you think, would it make sense to correlate CRP to NFL?
You're looking, until you do something, first of all, you never know the answer. So it's always, the first thing I would tell everyone is I don't know the answer to that. And now that I've said that, I'll give you some thoughts that I'm thinking about as I'm asked that question. You're looking at the measurement of different things. You're looking at, on one hand, you're looking at nerve damage. On the other hand, you're looking at muscle loss. So you're looking at two separate items. Are they correlated? I don't know. It's just sort of rudimentary. One is measuring muscle loss that you can test by overall survival. The other's more looking at a neuronal issue, which you can correlate also with effect. So it's always worth trying. I'll be probably more interested in serum creatinine, but I think that you can look at both.
Thank you.
The following question is, are you suggesting that a new biomarker for ALS is not level NFL chain, but only CRP, or whether CRP and SC levels would be an easier way to diagnose ALS? If you could clarify that a little bit.
The word biomarker is sometimes a term of art. So
Yeah.
Let's start with what we're learning. Could it be a predictor? I would say that based on the SCREAM data, and then based on some of the data that was based on the SCREAM data, there are two different publications. The second one was by Sun, looking at the same data. It looks like it's predictive of a patient course. So I believe you still have to correlate with either a vital capacity or some way of looking at lung function. Because at the end of the day, there has to be a there. So why is it important for muscle mass? Breathing is very, very important. Why is nerve important? For obvious reasons, plus the nerve to your lungs, your phrenic nerve is of vital importance when you look at progression of ALS. So I think more research is needed, but I think the overarching learning point from what I'm trying to say is, instead of looking at ALS as just nerve damage, this is a disease, it's striking the nervous system, it's striking where the nervous system is touching the muscle. Another way of looking at it is this a disease that's immune-based, that's from the innate immune system? And can I correlate that? Can I correlate that with NFL? Can I correlate, as I think the question was great, can I correlate C-reactive protein with NFL? And I have no doubt that research is done. I'm not familiar with all the variations of the research, but it's another way of looking at it, at a fairly complex disease that strikes people in a different way. And can this be an explanation of why some people progress, why some people don't? Could it be part of your ability to regulate your immune system?
Thank you. And I think we have another question kind of related to, continuation of what you were saying is, many of the people who get diagnosed very early do actually say that they have less liver enzymes elevated in early diagnosis. Have you noticed that as well? Or is this again observation?
My data is more of an observational nature. So I don't believe, I think there are people wiser than myself that are probably on this call that have more experience to answer that question. So sometimes it's best to say, I don't know.
Thank you.
Thank you. And there was a kind of a question about prednisone and why would it work if we're talking about an autoimmune disorder or an underlying kind of immunity issue, then why wouldn't prednisone be at all effective?
So I think I'm going to talk a little bit general and then go specific. So my last place that I was doing research, we were looking at multiple sclerosis. And about 2 months ago, you had a really intriguing lecture about someone who talked about diet and the effect of how she was able to treat herself with multiple sclerosis and how she was treating patients, and they started to walk by having a very specific diet regimen. And I commented, I think it was about 2 months ago, that there's been some very interesting correlation with specific types of diet and your immune system. So the key is, if you can regulate, not turn off, but you can regulate your immune system. And usually, as an example, if it's in your brain, it's your microglia. Let's say it's circulating, it's macrophages. But they're usually in one of two states. They're in the inflammatory state, in which they're basically calling all the rest of their friends, all the rest of the immune system to come and fix a problem, or they're in a repair state, homeostatic state, in which they're able to affect change, get rid of the proteins, get rid of dead cells. They can't do both at once. And so a perfect goal would be to get your immune system from, we used to also call it M1, M2, but to get your immune system from the inflammatory state back to that self-regulating state. Now, if I give something like prednisone, it's a great anti-inflammatory, but the problem is it's a great anti-inflammatory. So it's affecting your entire body. And eventually there's very pronounced side effects of continuous use of prednisone. And that's sort of very different than what I would I have to be careful how I say recommend, of sort of the lesson I'm trying to impart, and that would be that regulation, but not turning off the immune system, would be an intriguing avenue. Would prednisone in neuroinflammatory disease, multiple sclerosis, would have some positive effects for a while. It could. It's a great anti-inflammatory, but are there very dangerous long-term effects if given constantly? Yes, and only your physician can sort of regulate that risk and the balance between the two. And there's always justifications when that's discussed with the patient. But intriguing research would be to try to dysregulate that cycle so your immune system can still work, but not constantly be in that point in time where it's in the inflammatory state instead of the repair state. That would be sort of a dream.
Well, thank you very much, Dr. Davis. And we are very excited about Neuvivo and what you're working on. And we can't be thankful enough for you and your team to be actually working on behalf of us and the ALS community here. And we're just very eager to hear more. So thank you very much. And with that, I'll hand over the next session to McFinn. And thanks to my colleague Christian here, who moderated the session with me.
Thank you so much.
Thank you.
And thank you to everybody. Look at this. Our extended family meets again. We all have something in common. And sometimes we have little gifts that we bring to share. Pathfinders, we have some with us tonight. An amazing new group of people who have ALS and a few who are caregivers. And they've really stepped up and created, or let's say our group created an app, and it's at the App Store, the Apple Store. You can go to the App Store and just type in everything ALS app, or you could go to the Google Play Store and you could type in everything ALS app, and you get to meet the Pathfinders and yourself, because there's a lot more there than just the Pathfinders. There are 9 Pathfinders, and they are dedicated to making sure that you feel supported. And the app, direct communication with us. If you just download, it's very simple. A little download, a little password, and you're in. And the Pathfinders are, as they say, available, because sometimes Pathfinders, they just need you to fulfill that purpose that they have taken on in their life. And with that, though, we've got a Pathfinder, and his name is John. John, come aboard and say a few words.
Yeah, I'd like to talk about the app a little bit. We went through it as a group a couple of weeks ago. And even though I've been around the foundation of this for a few months, once it finally got developed, it's really, really useful. One of the things they had on there that I didn't think was of much use was a daily log. Now, I'm fairly slow progressing, but I will say that when things pop up and your conditions change, you know they change, and then you learn to deal with them and you move on. But when it comes time to talk with your healthcare team, 3 months later, you forgot when that happened. So I've been using this quite a bit. As I start losing a little bit of function, I can make a quick note to myself, and it's real simple. Once you go on there, you'll see it under daily log. But it's a great little tool that you normally have in your pocket. And that way, when you go and talk to your health team, you can say, it was 3 months ago that I wasn't able to do X. So I'd please ask you to look into this app and try and use it.
Thank you, John. Those are the kind of things, folks, that they're little helpers that are there 24 hours a day. That's why we developed that app, so you can have something in the middle of the night you wake up, you want to work with yourself, there's something to work with. Another one of our Pathfinders, Sean. Sean, can you say hello to everybody?
Gotta find my cursor first. It's not always easy to unmute. Yeah, no, hello to everybody. And I've just been looking on my app as well, just to sort of figure out if there's been any messages and just keep checking up on it. And yeah, it's a very interesting app that way. And I like the motor movement exam on there. You can keep track of your scores, and they've got a different kind of, not just the FRS, but a motor movement exam on there as well. So kind of useful, kind of different. So, and then all the talks are there as well. So if you do need to look at an old talk, you can scroll through there and find the old ones and watch them as you need to. So somebody in the chat was saying they wanted to watch this program again. So it'll be on the app here in a couple of days. So always something useful.
Thank you, Sean. That's, folks, you're meeting these personalities who are offering their time, their heart, and their soul, and their experiences to you. And I couldn't think of a greater gift to have somebody who's in the same position as you are, to be able to speak with them. Janie, can you just say hello? Janie is one of our Pathfinders. She's getting ready to go to the conference. Tell us about
Yes, I really do appreciate the app. I originally thought, because I'm wheelchair bound, with the movement tasks, I wasn't going to be able to do those. But there are, things that are important that, like squeeze your eyes, that kind of thing. So don't skip over that just because if you're wheelchair bound. And I do check the app as often as I can. I know they're working on push notifications. So, be patient with us if we don't respond, right away. But I do try to check it at least like once a day. So it's nice to meet everybody.
Thank you, Jamie.
You're welcome.